Disclaimer: this video is solely for education purposes, no financial interest involved. In this video, we will discuss regarding phacoemulsification strategies in traumatic cataracts. Let's go through the case number 1. This is the case of traumatic cataract with ruptured anterior lens capsule. After the initial steps of phacoemulsification, continuous curvilinear capsulorhexis was done using cystiotomy needle. Anterior chamber is formed using viscoelastic substance. Main port entry is done using keratome knife by triplanar incision. Microscissors are used to make ruptured capsule look circular. Anterior chamber is formed. Limited hydrodissection is done since there is no clue regarding posterior capsular integrity. Cautious and controlled irrigation and aspiration is done using Simcoe cannula in cases of traumatic cataracts. Anterior chamber is being formed. Here we notice that the cortical matter is not being easily aspirated by using Simcoe's cannula. After careful observation, vitreous strands which are coming in the wound are seen, which are cut with a Vanna scissor. Side port is being made. Now the anterior vitrectomy is completed using 25 gauge vitrectomy cutter. It is noted that the irrigation port is upward to prevent hydration of vitreous. Now we can see that the cortical matter as well as the vitreous is being aspirated by aspiration cannula. Now the viscoelastic substance is being filled in the anterior chamber, and now the lens implantation is done by 3-piece intraocular lens, which is specially for such cases of traumatic cataract. The lens is being implanted into the sulcus successfully in the patient's eye. Let's see the case number 2. This is the case of traumatic cataract with subluxation of 2.5 clock hours. Side port is being made with MVR blade. Air, dye, hydro and visco is being injected. Continuous curvilinear capsulorhexis is being made with 26 gauge cystiotomy needle. Main port with keratome knife along with side port is created. Now we can observe that the capsular tension hook is being applied to the area of subluxation in order to provide the support to the subluxated area of around 2.5 clock hours. We can observe the gap of subluxation before and after the application of capsular tension hook. Limited hydrodissection is being done in this case of traumatic cataract. After that, phacoemulsification of the traumatic cataract is being done as shown in the video. Leftover part of the cortical matter is being dialed using Sinskey hook. Anterior chamber is formed. Leftover phacoemulsification is completed. Anterior chamber is formed, and after that bimanual irrigation and aspiration of leftover cortical matter is being done using irrigation and aspiration cannula. Kindly note that the irrigation and aspiration of cortical matter is being completed here. Anterior chamber is formed. After that, posterior capsular intraocular lens is being implanted with capsular support in place, providing appropriate strength to the bag, followed by IOL dialing and proper centration of IOL. This picture depicts posterior capsular intraocular lens in the place and well centered. Now, The capsular tension hook is being removed as depicted in the video. Now the side port and main port is being hydrated. Leftover viscoelastic substance in anterior chamber is being aspirated using irrigation and aspiration by Simcoe cannula. A single and well-centered air bubble in AC rules out the presence of vitreous in anterior chamber. This is AR reading of this patient who is happy and satisfied after surgery. This was the position of bag, as bag did not have support of zonules. So, to ensure safe phacoemulsification, bottle height should be decreased, irrigation port should face upwards, and there should be limited hydrodissection. These key takeaways highlight selection of most appropriate approach, emphasizing patient-centered care and surgical precision. Thank you, everyone.